Well, hello. It's nice to have you again here in South America.
Well, thank you, Armando, for this very kind invitation. It's a beautiful meeting at a great venue, Cartagena. Lovely people, very warm. It's my pleasure and honor to be here.
Yeah, thank you. So let's talk a little bit about the future of the CSP. So I would like to, the first question I want to know is, there is a recent publication about some patient with a dense scar. I don't know if you read it. The study tried to evaluate the level of the scar in the septum and tried to predict which people going to be better with the CSP or not. So, and that's happening in real life. Sometimes you have a good penetration in the septum, you have a very good parameters in the X-ray, but you cannot engage the left bundle. So tell me something about it. Tell me, do you think we have in the cutting edge technology now in the area, or do you think we have to improve the tools, or have to improve the operator's skills?
Yeah, I think it's important to understand that there's no one size fits all, right? Conduction system pacing is an option for cardiac resynchronization. But if a patient has a lot of scar in the septum and the conduction system is diseased as a result of it, then conduction system pacing is not the solution. That is the kind of patient that will do better with bi-V pacing. If you have a patient that doesn't have a lot of scarring, or maybe the scarring is minimal in the septum and the conduction system is preserved, maybe in that case a better tool or lead that can penetrate that area of scarring, the minimal scarring, and get to the conduction system might be the answer. I do think that MRIs do offer that information ahead of time. So if we're able to pre-screen these patients with MRIs, particularly those that have a very low ejection fraction, very bizarre QRSs, in those cases I think it's worthwhile getting an MRI up front, understanding where the scar is. If there's a lot of scarring on the lateral wall, then CRT may not be the strategy we should go for. If there's a lot of scarring in the septum, then maybe conduction system pacing isn't the strategy we should go for. If there's a little bit of scarring in both areas, then maybe hot or lot CRT, where you combine both those strategies, might be the way to go. So I think it's important that we start tailoring the approach for cardiac resynchronization based on the underlying patient phenotype. And that would be based on ECG evaluation, maybe some form of imaging like cardiac MRI, which gives us high definition imaging about scar and so on. And then other technology such as the REST and so on might be helpful in guiding that therapy going forward.
Okay, but in your clinical practice, day to day, I mean, you try to perform cardiac MRI of all of those patients, because there are millions of patients that are every day sent to you by the clinicians,
Right.
to do a CSP. So do you perform MRI on all patients or some of them? Or you have any suspicion of which patient is going to be better with MRI or which patient will not?
Yeah. No, so I think there are two things that I'm thinking about. In the ischemic cardiomyopathy patients, we already know where the scar is based on a stress test, nuclear studies, based on Q waves on the ECG. So a lot of that is answered in the ischemic population. When it comes to the non-ischemic patients, then a lot of times our patients will have an MR evaluation to make sure we're not missing sarcoidosis, in this part of the world, Chagas disease, all of the non-ischemic etiologies we should be thinking about. But as an electrophysiologist, most often when the patients are sent to us, they've already had that evaluation. Now, if I see on an ECG a very classic left bundle of 160, 170 milliseconds, and everything else looks okay, maybe I won't necessarily put them through and then the history, how long did the non-ischemic cardiomyopathy last for? If it is a patient that has a very wide QRS that's bizarre, left bundleoid, 220 milliseconds, then there's more going on. You should do your due diligence with an MRI or some form of advanced imaging before you decide what's the best resynchronization strategy for that patient. It also helps you plan. So if you say the patient has a lot of scarring and you may need to do hot or lot CRT, Then you need to pick the kind of device and the type of lead you're going to use. The RV lead, the defibrillator lead may need to be a DF1 lead. So in pre-procedural planning, knowing all of that, as much information as you have, helps you be more precise and more efficient in the procedure.
So, and do you think the companies need to improve the tool we have now? Because we have using the same lead, the same sheet during the last, I don't know, maybe 10 years. So do you think the industry and the companies need to improve tools to improve the results of the CSP?
Sure. No, I mean, I think they've done a lot of work in the sheet space. There are a lot of delivery tools now from each of the manufacturers that will successfully get you to the his bundle or the left bundle region. The leads certainly need more work. The only lead that we have long-term data for is the Select Secure Medtronic lead. The other leads are starting to have more and more data is coming out on them, but most of it is midterm, 6 months to a year. We need more longer-term data with those. And none of these leads, including the Select Secure, are dedicated for conduction system pacing. So yes, we need more leads that are dedicated, that will stand the test of time. And more important than all of that, we need devices that are dedicated, algorithms that are dedicated for conduction system pacing.
We have not.
We don't have any of that. Auto capture algorithms, things that will help us, for heart or lot CRT, auto AV delay adjustments. These are all things that will help us ensure capture of the conduction system and make the follow-up of these patients much more seamless than it is today.
I got it perfectly. And how many of your patients do you perform a lot instead of baby pacing or just CSP?
Yeah, so I would say it's a small percentage, maybe 5 to 10%, but there's a good way that we figure that out in the middle of the procedure. So I usually put a ablation wire on the lateral wall and pace the conduction system. If I pull the lateral wall activation time using the measurements in that coded vision wire completely, then I don't need anything else. If I don't pull it in at all, then I need BiV. And if I pull it in partially, then I might be able to combine conduction system pacing with CS pacing. And so that's the population we go hard on that CRT.
And it's not consuming time for you or for you to clinical practice?
It probably adds another 10 or maybe 15 minutes at best.
Number 10.
So I think in the pre-procedural stage, if I see a patient with an EF of say 15-20%, LV is very dilated, the QRS is over 200 milliseconds, that's my clue that this patient might need heart or lot CRT.
Great. And what do you think about the special population? I mean, older people, young people doing CSP, because much of the data is around middle-aged patient. So let's think about the no common patient. I mean, very old patient or very young patient. What do you think to use this kind of technology in that?
Sure. I mean, I would say in the elderly population, it probably is better because you're minimizing hardware. If you can achieve cardiac resynchronization with 2 leads instead of BiV, which is 3 leads, you're minimizing hardware in an elderly patient that is at a higher risk for infections, multiple comorbidities. So I do think there's value in that subset of patients. In the younger population, if we're talking about pediatric kids that are still growing, then I think, we still need more data. There are some papers we've published in that space, but we need to see long-term extraction ability. These are younger patients. How do these leads perform? So optimistic, but with caution. In patients that are grown up enough, 15, 16, late teenage years, I treat them more like the general adult population because the growth spurt, which is going to impact how these leads and their slack varies and their stress and strain varies, is hopefully beyond that point where they're still growing. So that's how I usually break them down. I've done a number of cases of conduction system pacing in younger kids with congenital heart disease, TGAs. We published those. For a lot of those implants, we use mapping so we can identify where the conduction system is. And oftentimes we'll give it an excessive alpha loop so even as they grow, the leads don't get pulled back. But there's concern that with too much of an alpha loop, will the lead push through into the LV cavity as well? So there's pros and cons that you have to weigh, but careful follow-up is the key in those patients.
So what do you think about, Roy Tong told us a couple of days ago about the usefulness of mapping left bundle before implant. So it's going to be, for my opinion, take more time the procedure, go through the aortic valve, So I would like to know what's your opinion about this approach.
Yeah, so I think, the work that Rod has done is very, very fascinating. It certainly has helped us all learn a lot. I think there's a lot of value in learning more on the left-sided capture, defining criteria, and so on. But from a day-to-day practice standpoint, it may not be as practical. There's the risk may be low of doing additional steps, but certainly adds more time. And not every center will have the bandwidth to apply that in routine clinical practice. Now, maybe there are a subset of very small patients, dilated cardiomyopathy, like that heart and not CRT, where either doing the vision wire technique that I do, or mapping the left side of the septum, gaining some more knowledge about what the conduction system is doing in response to pacing it, there might be value in very select patients. But it's more, to me, a research tool, helps us understand academically what we're doing right and what we can do better.
And in your clinical practice, again, what do you do when you have a good penetration, but you cannot engage left bundle? It just happen. It used to happen. No, it's not so abnormal. You find it day to day. So what do you do in those cases?
I certainly will try to think about the general reasons why I'm not able to do that. So, try a different site, maybe come back out and go to a different area. Also remember, oftentimes the septal leaflet of the tricuspid valve sits right there. And so a lot of people will just pin that, and that might be why you'll get in a little bit, but you won't go any further. Lead entrapment is a phenomenon that has been described. So if I've gone through all of those, scar in the septum is a possibility. If I have data that suggests there's scar in the septum, then in those cases for a CRT indicated patient, I'll just go put a BIV in. For a Brady population, maybe LV septal pacing, but there's data that's coming out that suggests it may not be ideal as well.
Yeah.
So maybe a slightly more distal site in the septum that'll engage the Purkinje fibers may not be the left bundle trunk, may be the next approach.
Perfect. So thank you for your time. I know you're moving to Florida, so you're going to be near South America. So I hope you're going to stay with us next year in Buenos Aires.
I would love to be there and continue this journey.
Thank you, my friend.
Thank you for having me.